Welcome, everyone. My name is Leslie Verner, and I'm the Director of Programs for Carolina Breast Friends. We are so pleased to have Dr. Rob Dufour with us today. He's a board-certified radiologist with Mecklenburg Radiology Associates, and he specializes in diagnostic radiology and women's imaging. He graduated with honors in 2014 from George Washington University, and he completed his internship and his residency at UVA in Charlottesville, Virginia. That was followed by a fellowship in women's imaging at Wake Forest University. He is currently affiliated with Novant Health. Dr. Dufour, thank you so much for being with us today.
Thank you so much for having me. It really is an absolute honor to be here. And just within the couple minutes I've had getting to know you, Leslie, and as other people have come in, I can just tell how special of a group and just a group of people and an organization that this is. So thank you so much for having me. It really is my privilege. Let me go ahead. I'll go ahead and share my screen. All right. So as Leslie had said, my goal with this is to be, a dynamic kind of conversation between all of us. So please feel free to ask questions as they may arise. And if you're not comfortable asking questions during the presentation, we'll certainly be happy to answer any and all questions at the end of the presentation. So again, just a little bit about myself. Been here in North Carolina for 2 years, did my fellowship at Wake Forest. Had a great time in Winston, and been in Charlotte now for a year with Mecklenburg Radiology. And we are a subspecialized radiology practice. So my specialty is breast imaging, which is what I did in Winston. It's just been an incredible time that I've been here. Love Charlotte, love my colleagues, and love my patients. And it's just now I get to kind of, in a way, consider you all my patients as well. And it's just what makes my job so rewarding and special. So thank you again for having me here. Thank you for being present during this. So with that, the presentation that I've been asked to do is on high-risk breast imaging myths and facts. I think the myths are something that I would love to kind of be part of the conversation, because I don't have many myths in this presentation, but we can go with them and kind of address them as they may come up. But hopefully I've got more facts than myths in this presentation. So we can go ahead and get started here. All right, so first with this presentation, I think we should define high risk. And this is defined by the American Cancer Society. And probably the most simple way to define high risk is someone whose lifetime risk is somewhere between 20 and 25% or greater of developing breast cancer. So unfortunately, breast cancer is sadly very prevalent for women. It's 1 in 8, or basically 13% of women will develop breast cancer in their life. So where this actual designation of high risk comes is when it's 20 to 25%. And what this is based on largely is family history. So a first degree relative, as a mother or a sister or a daughter, carries the greatest risk. But this is really a calculation that is actually performed to determine what your risk is. There are other things that would deem you high risk, and one is a genetic predisposition. So we hear a lot about BRCA1 and BRCA2 mutations, and really what those are, they are proteins, BRCA1 and BRCA2, that help damaged DNA. And what happens is for BRCA1 and 2 carriers is that there is a mutation in that doesn't allow it to actually repair the damaged DNA. So what they are good at repairing DNA so that cancer doesn't develop. But people who have the mutation, that protein doesn't work. So damaged DNA continues to proliferate and potentially become cancer. So that puts someone at high risk. Specific genetic diseases and syndromes, some of them are off the top of my head, Li-Fraumeni or Cowden syndrome. Another thing would be Ashkenazi Jewish descent, something that could place you at high risk. Another less common one is radiation therapy to the chest. This is usually for, and it's between the ages of 10 and 30 years old that you would have radiation therapy to your chest. So for cancer, breast cancer patients who may be getting radiation therapy, that doesn't quite, it's not being captured here in this. This is really for young women who are getting radiation to their chest, for instance, for something like lymphoma. And then down below the dotted line, these are some things that can put a patient at high risk, or I'm sorry, moderate risk, but not necessarily define you as high risk. So moderate risk would be an actual history of breast cancer or atypia. And we can go into atypia if anyone has any questions about what that is, but it's generally a precursor to a malignancy. And then extremely dense breast tissue is something that is important to talk about. It gets a lot of talk, and rightfully so. It is something that is not completely defined, whether or not it does place someone at an actual high risk, but we do know that someone who has dense breast tissue or extremely dense breast tissue, there are two things that happen, is that we do believe they are at an increased risk of developing breast cancer. To what extent, we don't know, but we do believe that it's slightly higher. The other thing is that detection of breast cancer is much more difficult in someone who has extremely dense breast tissue. And so what I'm going to show is here we have A through D, and this is showing the 4 categories of breast density. So breast tissue is made up of fatty tissue and fibroglandular tissue. So kind of putting it simply, the fibroglandular tissue is generally the milk producing tissue of the breast, where the fatty tissue is the other part of the breast. And how those two tissues interact is really what gives the architecture of the breast. And here we see the density. So A is almost entirely fat. So fat, X-rays travel exceptionally well through fat. So fat turns out to be pretty dark. That is more black, where glandular tissue, you can go all the way over to D. This is extremely dense, and you can see how it's very white. And so these are kind of the in-between steps. So scattered, heterogeneously dense, and then extremely dense. So you would see that on your mammogram report. Everybody gets a designation. Every patient that we see gets a designation of what your breast density is. So again, almost entirely fatty tissue is here, scattered fibroglandular tissue is here, heterogeneously dense, and then extremely dense. And so, as I was mentioning, the reason why it's really difficult to detect breast cancer in a patient who's got dense breast tissue or extremely dense breast tissue is here. We saw that fatty tissue has a black background. This has a white background. Well, it turns out that cancer on a mammogram is oftentimes white. So it's finding a white dot on a black background is much easier than seeing this cancer, which is a white cancer on a white background. So that's why it's very, very difficult. Extremely dense breast tissue makes it harder for us to do our jobs in interpreting mammograms because of that. So this is probably less than a centimeter in size cancer, and we see it very easily. This is probably 3-ish to 4-ish centimeter cancer, and it's very, very difficult to see. So that kind of touches on breast density. One of the other things is, so now that we've kind of defined high risk, then the question is, well, how do we manage it? Well, so once we know that someone, those things that I talked about earlier, whether your lifetime risk is between 20 to 25%, or you have a BRCA mutation, well, then, somewhere at Novant, we do have a high risk clinic where you can go in and you can meet with a geneticist. They do these calculations, and they determine whether you are at high enough of a risk to begin screening mammogram early. So beginning screening mammography at age 30, and then also supplementing yearly mammograms with breast MRI. And the reason, unfortunately, that it's important to get this designation is for insurance purposes. Obviously, the cost of healthcare is probably more expensive than any of us would like it to be. It's unfortunately very expensive in our country, and but we have great healthcare, but unfortunately it does come at a cost. So we want to make sure that it is covered if the patient it has all of the information as possible to have it covered. So that's what's most important about actually having that designation as high risk. So the most important aspect of this is this yearly screening mammogram, alternating every 6 months with a breast MRI. And the reason that that's important to alternate every 6 months is that gives us an opportunity every 6 months to take a look at a patient's breast and to see if anything's changing, anything's growing. But the other thing is that mammogram and breast MRI really kind of complement one another, as we'll talk about with ultrasound at some point. They show different things. And so a mammogram is able to pick up cancer that may be very, very subtle or almost non-detectable in a breast MRI, and vice versa. So they're both very, very important modalities or imaging techniques that we have in order to diagnose breast cancer, hopefully as soon as possible. And the other thing, just to kind of go back on, is the screening 10 years prior to a family member diagnosis. So that's generally for a first degree relative. So if a mother was diagnosed at age 35 or a sister were diagnosed at age 35, then generally speaking, we would subtract 10 years from that. So at 35, you would then start screening mammography at age 25. So that's kind of a rough recommendation there.
I think Stephanie might have a question.
Yeah, I do.
Yes.
Thanks, Leslie. Just had a quick question on kind of your take on I'm going to say like harshness of the contrast dye if you're starting those breast MRIs with contrast. So I guess so young. I know
Sure.
I've seen a few studies out there, so I was just curious on your take on that with having that as frequent.
Absolutely. So there's a lot that's going on right now with studying MRI contrast. So a lot of it is where it deposits. The majority of it, the vast majority of it is excreted by the kidneys and comes out as urine. And so that's the way that we really excrete the majority of it. But there is some that we have some data that shows that it may be deposited somewhere in the brain, and that is still ongoing, and what the potential side effects would be of that. So I think, just as with anything, we have to think about the risk and the benefit here. So as far as where I'm kind of going with this is because yearly breast MRI, that's if someone were to start at age 30, that could be 40 years of having a breast MRI. So that could end up being a lot of contrast. I think my opinion would be knowing, when you look at what makes someone high risk, right? 20 to 25% risk of developing breast cancer. The risk of having this dye is outweighed by the benefit that we get from detecting breast cancer as early as possible. So it's a really good question, and it's still ongoing. And you do see some patients who prefer to, instead of having it every year, they'll do every 2 years for a breast MRI or every 3 years for a breast MRI. And really that's kind of a personal, I think, decision, as we don't know the full extent of some of these contrast agents. And the other thing is there are a lot of contrast agents that are being developed and that have a much safer profile and may not be deposited elsewhere throughout the body. And so it's ongoing, and it's a great question. And I wish I had a better answer, but I really think it kind of comes down to, the risk and the benefit of getting this, the breast MRI, because it is the most sensitive test that we have. And when I say sensitive, I mean it detects cancer the earliest. It's most likely to detect a cancer out of all the other modalities that we have. So mammogram or ultrasound, breast MRI, we are less likely to miss a cancer with breast MRI than any other imaging that we have.
Thank you. Understandable answer. I appreciate it.
Of course.
I have a question about breast MRI. It can be so uncomfortable. Are there any machines coming down the pike that might make it an easier experience for women? We have to lie on that bar that kind of goes underneath the breast tissue for 45 minutes or whatever, and it's very uncomfortable.
Yes, yeah, and that is another quite a negative with breast MRI is how long it takes. Some patients who have breast MRIs, say of the brain, that's there's claustrophobia that's involved with this, but they are able to lie on their back and relatively, I think claustrophobia is the big thing. But I know with a breast MRI, it's very, very uncomfortable, like you said, to be on your stomach, and the positioning is really tough. You have to stay super still. So I think the big thing with breast MRI or MRI in general, is that we have a lot of competing manufacturers out there that are really at this arms race to try to get acquisition time of MRI as quickly as possible. So, like you said, a 30 or 45-minute breast MRI, there's just tons and tons of money and research going into making that 30-minute breast MRI, hopefully 20 minutes, within the next, say, 5 years or so, and getting it down as quickly as possible, because then that allows us to see more patients. We don't have, who are able to get breast MRIs, as opposed to having a long month-long list of people who are trying to get their MRI. So I think cutting down on the time that it takes to get a breast MRI, and then I think as far as the positioning, I'm sure someone's working on that, because that's definitely a complaint that we hear a lot. So it's well heard, it's for sure.
Thank you.
Of course. All right. So I think what we can go next to is just kind of going through some of the essentials of breast imaging. And as I've used the word modality a couple of times, but basically the imaging machines that we have available to us. And so we have mammogram, of course, ultrasound, MRI, and we get to use these in an array of ways. So we can start with mammogram. So a screening mammogram is really how we get to see most of our patients first. So a screening mammogram, as we talked about, is somebody who most often starts at the age of 40, unless if they are high risk and we need to start sooner. And what a screening mammogram is somebody who has basically no breast-related issues at the time. They're not experiencing pain. They don't have a lump. We're not following anything. If they have a history of breast cancer, it's been several years since they've been cleared of that cancer. We're just following it. It is just routine. It is screening. And so with a screening mammogram, likely you wouldn't be seeing a radiologist. You would go in, you'd get your images read, you'd have that report, within a day to a week. And what we do is 4 basic images, as we see here, this CC, which stands for craniocaudal, which just means that one comes from the top, kind of cranium, and then caudal kind of means tail. So kind of coming up from this way. And then we also have MLO, which stands for medial lateral oblique, and oblique because it's kind of at an angle here, but medial means closer to the center of the patient. Lateral means closer to the periphery of the patient. And so the reason we do this is because we always want orthogonal views, meaning that we have them in 2 different directions, so we can tell if something has more 3-dimensional qualities, but then we also are able to triangulate it better. So we can tell where in the breast it is if we ended up needing to do ultrasound or whatever else. That's how we kind of figure out in our mind where, say, a new mass would be. And then so after the screening mammogram, generally about most of the time, about 90% of patients who get a screening mammogram are are free to go. It's negative. See you next year, unless if something else comes up like pain or a lump. But for about 10% of patients, they are called back, and they are called back to a diagnostic mammogram, which just means that something was seen that we want another look at. So really at a screening mammogram, there's two outcomes. There's normal, see you next year, or you need to come back for additional imaging. So here is, let's see. So what I'm going to go into is what we look for in screening mammograms, and we'll go into diagnostic mammogram later. But this is really what we're looking for. And I'll go over this pretty quickly, but these are a couple examples of breast masses that we have on mammogram. So we're really looking for, again, something that's in the background. This is obviously standing out. This is a mass here. It's very round. It's got really sharp margins to it. So what we're looking for is just the characteristics of it. The more round, circumferential, as we call it, you'll see in our reports, the more likely it is to be benign. Here we have a little bit of irregularity to this. You'll kind of see a little angle there. It looks like a little spike almost. It's not a perfect circle. This is more suspicious here. This is certainly something that we'd want another look at. Certainly it's very large and we'd want another look at it. And then here we go to something that's, we use the word spiculated. I think of these little spicules like spikes, almost like little tentacles that are kind of coming out. And this is a highly suspicious finding. This is almost always going to be something that's malignant. So this is kind of what we're looking at on mammogram. The other thing that we can look at is calcifications. This is one of the most common things we look for on screening mammograms. There are a lot of benign calcifications out there. We don't need to go over all of them, but that's one of the main things we're looking for. And then calcifications can also be the very first sign of breast cancer, as I'm sure plenty of people who are listening to this can attest to. It's one of the things we take most seriously because, again, our job and our hope is to, we know that they're going to be breast cancer, and our job is to detect it as soon as possible. Early detection is really the name of the game, and finding that through calcifications is one of the best ways that we can. So this is just kind of an overview, but a lot of these calcifications, just so you can see a large amount of, we'll see these with post-surgical change. So women who have lumpectomies or any sort of surgical excision can develop these calcifications, these really large kind of chunky calcifications. Something called fat necrosis, which we see is basically, for lack of a better kind of simple phrase, it's bruising in the breast or trauma that goes into the breast, and it's just the way that the fat responds to that trauma, and it eventually will calcify. And then here are the more suspicious calcifications that we would want to biopsy and figure out, are they benign, or are they atypia, something that could at some point become cancer, or is it cancer? So these are masses and calcifications are two of the main things that we look for in mammograms. And so if we were to see something like that on a screening mammogram, again, we would do a callback where we have additional mammogram pictures available to us that we would do, and also ultrasound. The other reasons why we would do a diagnostic evaluation, which is where you would see a radiologist, or at least the radiologist would be there real time looking at your images, whether or not you were to see the radiologist or not, the radiologist would be looking at it real time while you're in the clinic. So that way, if I needed to see you, talk to you, do an ultrasound, tell you that I think we need a biopsy, I'm there, you're not leaving the clinic. And these are, again, abnormal screening, a workup of a problem. So again, someone has pain or swelling or a lump or nipple discharge or redness on their skin, these sort of things. There's a problem. History of malignancy. So if someone has breast cancer, we typically like to see our patients for 2 years following their surgery and their treatment, completion of their treatment, 2 years, so that we get to have a really close follow-up of what's going on in their breast. And so that way, if we need extra pictures or an ultrasound, you're there in the clinic and we can do it then. The other thing would be a short interval follow-up. If we feel almost 100% that something's benign, but we're not quite there. Generally, it's kind of at a 98 to 99% that it's going to be benign, but we're not quite there. We'll follow it. So we'll follow it for 6 months and another 6 months, and generally for 2 years before we call it benign. And so you would come in as a diagnostic evaluation there. But generally what happens is we have some extra pictures. We'll do more compression. If we're looking at calcifications, we get a much more magnified look, better characterization of it. And then the diagnostic ultrasound is very important. That shows us a lot about a potential mass or other findings in the breast that a mammogram wouldn't. And so here's what breast ultrasound can show us is that a mass really, aside from the margins, the borders that I showed you before between kind of the more benign and more malignant mass, what an ultrasound can do is differentiate between something that is solid versus something that is full of, say, water, like this benign cyst here. So very common, we see patients come in with palpable lumps, and they just have a lot of cysts in their breast, which is good news in a sense, because cysts are cysts. They cannot become cancer, especially something like this that is just a simple cyst. It's really just a kind of a bag of water, and they can fluctuate. They can get bigger, they can get smaller, and they can cause some pain. But this is basically what a cyst is. It's just, so sound travels exceptionally well through water, and that's how an ultrasound works. Is it emits sound waves, and then the transducer receives it, and just the physics of how sound travels through the breast is what produces this image. And so sound travels very, very well through water, and that's what gives this black kind of hole appearance there. So completely benign. This, on the other hand, shows that this is solid. You can kind of almost, see that there's nothing in this but just water, but here there is tissue, and that's why it looks like that. This is, but likely going to be benign. This is a picture of a fibroadenoma, which is a very, very common benign mass that we see in women. And you can see how smooth this mass is. You could really take a pencil and draw the borders of it. This is a picture of a cancer. And this is not as smooth. It looks kind of lumpy, bumpy. It's got little angles to it. It would be really hard to perfectly draw a circle around here. The edges are kind of smudgy and fuzzy. So that's really kind of what we're looking for. So, we have a couple different tools in our tool bag, and mammography, ultrasound, and MRI are really the main things that we do to help characterize a mass. But the bread and butter is really ultrasound and mammogram for us to figure out whether we think a biopsy is needed or that everything's a-okay. And then here is breast MRI, which we've talked about quite a bit. So really the indications for breast MRI, because we don't recommend breast MRIs for just a woman who is at average risk of cancer, developing breast cancer, and without specific problems, just because of the things that we talked about. It's uncomfortable. It's a long study. You are getting contrast. Now you're not getting radiation because it uses magnets to produce this image. So it's non-ionizing radiation, which is good. It just uses magnets, but you are getting contrast, as we spoke about earlier, that we don't know exactly what the side effects could be of that. So that's really the main thing. Ultrasound, just to go back to it, ultrasound is probably our best tool that we have, because there is really no downside of it from causing any potential harm to the patient. It just uses sound. There's no radiation. You don't need any contrast. So just to kind of go back to ultrasound and why radiologists, but specifically breast radiologists, love ultrasound. it's a great tool that we have. So anyways, to go back to breast MRI, so the indications we talked about: high risk patients, patients who may have breast cancer, have a new diagnosis of breast cancer. The surgeon and the oncologist and the radiologist, we want to know how much cancer is there to determine, are you a candidate for a lumpectomy? Are you a candidate, or is a mastectomy a more appropriate treatment? How much of the breast is occupied by the cancer? Because obviously that's the goal of surgery, is to remove all of the cancer, and then the chemotherapy and the radiation is to obviously supplement that and to treat any cancer that may be left or within the body. So obviously surgery, we want to excise it all. And so you can see here, this is a small cancer in this right breast. And then we can see on this side, this is a large cancer occupying this area. And this is what cancer looks like. So it's enhancing. And that's why we do contrast, is because tumors are much more metabolically active in that they have a lot more cellular growth. The cells are developing rapidly, and so they have a lot more blood supply. So there's lots of little feeding blood vessels that go into tumors, because unfortunately they do grow quickly. That's the idea of them being a tumor. And so when we give contrast through the blood vessels, that contrast is going to go to a tumor quicker and more robustly than it would the background breast tissue. And so that's really the mechanism of why we give contrast, not only for breast cancer, but for many, many different types of cancer. That's the idea there, and why it is very necessary. And then we see another little cancer here. So that's a big reason why we'll do a breast MRI, just to evaluate the extent of the disease. Treatment response. Some patients will end up getting chemotherapy prior to surgery, and that's really to shrink the tumor and the cancer as much as possible before the surgeon would go in and remove the tissue. So evaluating how well did that chemotherapy work? What does the tumor look like now? What's the size of it? Just to give the surgeon as most information as possible to know what operation they can do to treat the patient the best. So mastectomy patients, sometimes we will do breast MRI if they have a nodule that feels like it's on the skin, just because with a mammogram, it's hard. It is hard to do a mammogram on a mastectomy patient because there is no breast tissue there, or a patient who had mastectomy with reconstruction. A lot of times we will do a breast MRI then. Problem solving, just in case if it's a unique case, and breast MRI is another tool that we may have. And breast implant integrity is specifically for silicone implants. Silicone implants can rupture, and there's a type of rupture that that can happen that we only are able to tell on breast MRI. So that's and that actually does not take contrast. That one we can do without contrast. So of course we exclude that. So the pros and the con, or the major pro and the major con of breast MRI from a radiology standpoint, is that it is very, very sensitive, which again, I went over that before, means that we have the best chance of catching a cancer and the least likely chance of missing a cancer. And it's so that's the other part, is that we end up catching a lot of things that aren't cancer, because sometimes it's hard to tell them apart. So so the pro is that we do a great job of catching cancer. The con is that it does lead to a lot of, they're not unnecessary biopsies, but they're biopsies that come back benign that can end up being burdensome to a patient because of anxiety, cost, an additional, the pain of a biopsy, potentially having a surgery that would take place if we didn't do the breast MRI. So they catch almost everything, and the good and the bad. So that's really one of the main issues to bring up with the breast MRI. And I know our surgeons do a really, really good job of bringing that up and kind of having patients expect that following a breast MRI.
I have a question about the MRI.
Sure.
For reconstruction patients, do you do follow-up MRIs on women who have had deep flap reconstruction, or is that not necessary since the tissue came from the belly?
That's exactly right. Yeah. So the tissue's coming from the belly. So really how surgeons and oncologists like to follow those patients are with physical exam. And usually with a patient that's had that kind of reconstruction, because in theory, there's no breast tissue left. In actuality, I'm sure there's small amounts of breast tissue that may remain, but the surgeon obviously does tries to remove any and all breast tissue that's there. So we don't screen patients who have had mastectomies, again, followed by physical exam, but we do see every once in a while patients who have had flap reconstructions or many different types of reconstructions, or just a skin sparing mastectomy, and they have implants, and there may be a new lump or a bump or a nodule, and in breast MRI is where we would do that then. So it really would become more of a diagnostic imaging as opposed to screening. Okay. So that's where they would the role that they would have there for a patient with reconstruction.
Thank you.
Of course. All right, and then this is my last slide, just to kind of talk about physical exam. Even though we're radiologists and we love our pictures, it's why we went into radiology. We love diagnosing through having all of these really incredible, cool pictures where we get to basically look inside and hopefully tell our surgeons and our oncologists and our primary care doctors and GPs what's going on to help them treat our patients and manage our patients. But we still can pride ourselves on our physical exam and looking holistically at a patient and talking to them and their signs and their symptoms and what has brought them to be in front of us. And so this is a very common thing. And this is, again, just very generalized, but we get a lot of patients who come in with pain. It's probably one of the pain and a lump are the most common reasons why we have a patient come in for a diagnostic evaluation. So I just kind of wanted to go through, and not that any of these are myths or facts, that they're not, because none of these are hard and fast rules. But this, again, is just when I'm seeing a patient and they're telling me about their pain or their lump or their skin changes, this is what's going through my head, just to kind of potentially equip you all with what for us is more concerning and maybe less concerning. But really, at the end of the day, if you or a friend or a family member were to have any of these issues, you still would want to be seen by a doctor just to have them evaluated. But again, so pain, where unfortunately breast pain is incredibly common and pervasive. I mean, it's and there's so many reasons why a patient could be experiencing breast pain. The times when I have a patient who tells me about their pain where it doesn't have me as worried is that it's generalized. It's the entire breast. It's both breasts. It's intermittent. It's cyclical, maybe with the patient's menstrual cycle. Maybe it's after they work out or holding, a child, or, a child's jumping on them or something. Where it gets more concerning is where a patient can point to it with a finger. It's constant. And really the thing that kind of raises a flag for me is when there's pain that's associated with a lump. And that's really where I'm going to do everything that I can to evaluate what's going on. I want to figure out exactly what this is. And just because there's pain with a lump doesn't mean that it's bad news. As we talked about, cysts are very, very common. Cysts can absolutely hurt, and they certainly can get big enough to feel like a lump. So that is a very common thing that we get to see. But of course, we need to do an ultrasound to be able to tell what is a cyst and what is a solid mass. So that's a really important reason to come in and be seen. And so again, going back to a lump, the reason I have fluctuates in size for less concerning is that's a really kind of telltale characteristic of a cyst. A cyst can kind of expand and contract as this water kind of gets filled into almost what I imagine is like a water balloon. It's a really thin lining of cells, kind of just the rubber of a water balloon, and it kind of fills with water and can, and then the water can kind of disperse out. And so they really do fluctuate over time. So when I have a patient that says, "Oh, well, it was bigger last month and now it's smaller," and that's one thing that raises to me that it's likely a cyst. More concerning is that it's new, it's growing, and it continues to grow. So that's something that would concern me. Skin changes, I didn't really put anything in less concerning for skin changes because really they should all be evaluated. But the things that I've listed here, this redness, thickening, dimpling, these are things that kind of inflammatory breast cancer is one of the things that's on the forefront of our minds when we have a patient who comes in with these sort of symptoms. Now, the trouble with this is that mastitis can cause a very similar picture. Mastitis is just inflammation of the breast tissue. And a lot of times there can even be infection. A patient can have an abscess and, would need to be treated with antibiotics. Inflammatory breast cancer is a scary diagnosis, and it's one that we are always looking out for. It's very rare, but it's something that we're always looking for. And so these are kind of some of the symptoms that we would see: the dimpling, this retraction, thickening. One of the words that we use it's a French word called peau d'orange, and basically it's kind of what an orange peel would look like, where it kind of has the little dimpling of the breast, just a lot of times from the swelling and the skin thickening that's going on. The other thing would be nipple crusting or retraction. Nipple retraction is a warning sign. Nipple crusting is there's a disease entity called Paget's disease, which is basically cancer of the nipple. And so if you get crusting, excoriations, just kind of a scabbing of the nipple, that's something to go talk to your doctor about. And nipple discharge is something we see a lot. If it is, sometimes we have patients who come in and they're like, "Oh, well, when you get your mammogram, your breast is in compression. And if you were to have discharge that were to come out there, or if a patient were to squeeze on their breast and discharge were to come out, that's less concerning than if it were to come out on its own." So spontaneous. So if you were to notice that there was discharge on your bra or your t-shirt or your nightgown, or, on your bed sheets or something like that, it came out without anything putting pressure on your breast, or you weren't in a shower. Sometimes a warm shower can cause discharge to come out. But when it's spontaneous, it happens for no good reason, that is something that's a little bit more concerning. Bloody nipple discharge is always concerning. And so that's something that should always be evaluated. One breast versus two, if it's one breast, it raises our concern more, because if it's in both breasts, it's more likely a systemic situation. Very unlikely that there would be breast cancer in both breasts that is causing the same sort of symptom. So if it's happening on one breast, it's would be more concerning. So I think that does it. I would love to answer any more questions or go back to any other slides that you all had. I know it's a lot of information, but I'd like to just open it up to y'all, or however you all would like the remainder of our time to go. Thank you very much for your time, and thank you for having me here.
That was amazing. All of your details were exactly what I was hoping for, because it's just gives us so much important information.
Thank you. That means a lot. Thank you. Yeah, well, it's an honor to be here. I mean, thank you for saying that.
And I'll just add, not another question, but I think it was helpful to see from a patient perspective, the image comparison of what a mammogram shows, what an ultrasound shows, and what an MRI shows. Because that's not typically, I think, in kind of an appointment and conversation, you typically see all three of those. So it's very helpful.
Great, good, thank you. Anyone else?
Don't be shy. This is your chance.
Okay. I also appreciated the details and the very educational way this was created, presented. I learned a lot, and it was very valuable to me. Thank you.
Thank you. I'm just overjoyed to be here, and like I said, I'm lucky to now kind of consider you all my patients as well, and I love the educational side of this. So it's definitely my pleasure. Thank you for saying that.
That comes through loud and clear. I can tell that you really enjoy interacting with your patients.
Yeah.
Anybody else? Well, Dr. Dufour, we are just so appreciative, and would love to have you back at some point in the future, maybe in person one of these days at Carolina Breast Friends when it's safe to gather in groups. And I want to thank Charlene for helping to coordinate this. It just was so easy to work this out, and thank you both for your time, and thank you so much for your experience. We appreciate everything.
Thank you again for having me. I would love to come back. So please keep me in mind if I can be of any other help or any other presentation, any other topic, or like you said, it'd be wonderful to see you all in person sometime. So please keep me in mind. I'd love that.